So, as Amy pointed out, a lot of what she ends up seeing and diagnosing are, precancerous cysts or IPMNs. And so my job here is to talk about really our advances in the management and diagnosis of these lesions. Because as you'll see, as I'll show you, IPMN is the most common type of pancreatic cyst we find, and it's really our one opportunity to potentially prevent pancreatic cancer. So I will go over some updates and controversies in the management guidelines for pancreatic cystic neoplasms, and we'll touch on some endoscopic advances in diagnosis and management. So the term pancreatic cystic neoplasms is really this throwaway term. Not all pancreatic cysts are equal. If you go back to the textbooks when all of us were in medical school, the short chapter or the short paragraph on pancreatic cysts would say that 90% of all cysts are pseudocysts. We now know that is wrong. Probably less than 10% of pancreatic cysts are pseudocysts. And you can see all the different pathologic subtypes that pancreatic cysts, again, that throwaway term, can be, including IPMNs, cystic degeneration of adenocarcinoma, and neuroendocrine tumors. So cysts are not something to, while most cysts shouldn't be fretted over, they should not be ignored and they should be evaluated. Many times, just based on a good clinical history and physical exam and a good examination of their morphologic features on imaging, you may be able to make a diagnosis. So typical example is this one up here, 57-year-old man, alcohol abuser, who develops a new large thick-walled cyst after a bout of pancreatitis. Most likely that's going to be a pseudocyst. Whereas, say, a younger woman with an incidental cyst in the tail of her pancreas, statistically that's most likely to be a mucinous cystic neoplasm. However, the vast majority of patients we all see, and you all see these patients, they usually have small cysts that are found incidentally on a workup for another reason. So, by and large, the vast majority of those cysts that you see, when you get that ultrasound report, the MRI report, or the CT scan that says a 1.7 centimeter cystic lesion in the body of the pancreas, by and large, the vast majority of those cysts are intraductal papillary mucinous neoplasm, or IPMN. So what the heck is an IPMN? So this is very similar to Barrett's esophagus. Satish talked about how Barrett's esophagus is a metaplastic change of the cells that line the esophagus from squamous to columnar. It's a very similar concept, only it occurs in the lining of the ducts of the pancreas. So in the main pancreatic duct and in the side ducts. And you get a metaplastic change, and that metaplastic change becomes nidus for neoplasm. So the most common type of IPMN are the branch duct IPMN. Again, these are the cysts that you see, that you get in your reports. They can look like anything. They can look like a simple round cyst. They can look like a cluster of grapes. They can be long and tubular. You can have more than one. Those are the typical branch duct IPMN. This can also involve the main duct, and it may manifest as a focal segmental dilation of the main duct or diffuse dilation of the main duct. I unfortunately don't have time to talk about main duct IPMN. This is actually a very serious condition because this has a very high association with cancer. But as you'll see, the presence of a dilated duct, such as with a branch duct, increases its risk of developing cancer. And again, you can have both main duct involvement, branch duct involvement, multifocal disease, or just branch duct alone. So how do we know when to resect? How do we counsel our patients and tell them, you have a cyst in your pancreas, it's an IPMN, on paper, technically, yes, this is a premalignant lesion. What do we do? Do I have surgery? Do we watch it? Do we forget about it? So the short story is that the vast majority, and again, I'll just go back to this picture, the vast majority of branch duct IPMN have very, very small risk of developing a cancer. It's about 1%, anywhere from 1% to 3% in the lifetime if you look at natural history studies. So that's a good thing. So how do we know which are those cysts that should be removed? So we do have some expert consensus guidelines. In 2006, a group of experts met in Sendai, Japan, and they devised a system where they said these are high-risk features. Anyone with a suspected branch duct IPMN who has symptoms such as jaundice, whose cyst size is 3 centimeters or larger, if the cyst contains a nodule, or if there's an associated main duct dilation, those would be considered high-risk features. This group met again in 2012 in Fukuoka, Japan, and they stratified the features a little bit differently. And the main points to take home are that what were considered high-risk features were the presence of an enhancing solid component, an enhancing nodule, and the presence of a main duct greater than 10 millimeters. Worrisome features, they downgraded that cyst size to 3 centimeters. They said it's not a low-risk feature, it's worrisome, but the risk of a branch duct IPMN over 3 centimeters being cancerous is not as high as we once thought it was. So based on these expert criteria, they said if you have any of these high-risk features, you should have surgery. If you have worrisome features, you should have further evaluation with EUS FNA. If that FNA demonstrated high-grade dysplasia or cancer, then you should be considered for surgery. So how well did these guidelines perform? And I should say that this is pretty much the standard that most surgeons and gastroenterologists have followed for the past 5 years or so. How well did they perform? So this is one study from the University of Pennsylvania where they went back and looked at all of the patients they had that they did surgery on for a pancreatic cyst that were suspected IPMNs, and they went back and they preoperatively applied what the Sendai and Fukuoka criteria were. So you can see that if they used the old criteria, they had a 92% sensitivity of finding cysts that were high-grade dysplasia or cancer, but a really low specificity, meaning there were a lot of false positives. A lot of patients went to surgery, probably didn't need it. The updated guidelines knocked down that 3 centimeter criteria and made it not high risk but worrisome, so maybe they wouldn't be rushing to surgery. And when you look at the performance of the 2012 guidelines, you have less false positives, but you also have lower sensitivity. And ultimately they concluded that using either of these guidelines was not great. And of the patients undergoing resection, only 18% of them actually had the thing that you would want to remove surgically, high-grade dysplasia or cancer. And they estimated that approximately 30% of these patients in their cohort never would have needed surgery altogether, and many of these patients didn't even have an IPMN. Given all the controversy, given the sort of cloudy guidelines that were out there, in 2015 the AGA devised their own set of guidelines. And you'll notice the difference. Here they talk about asymptomatic cysts. They don't mention IPMN, they don't mention specific cysts. They just lumped all the cyst types into one category. And they said if you have an asymptomatic cyst, this is how we think you should manage it. They made it very user-friendly. They came up with 3 high-risk features: size 3 centimeters or larger, presence of a solid component, such as you see here on an endoscopic ultrasound, or the presence of a dilated main pancreatic duct. And they kept that vague as far as the size. They said if you had a cyst with less than 2 of these high-risk features, you can survey the patient with an MRI in 1 year. If it's unchanged, repeat an MRI every 2 years times 2 for a total of 5-year surveillance. If you had 2 or more of these high-risk features, then you should undergo an EUS FNA. Or if you had significant changes on this surveillance, you should undergo an EUS FNA for further evaluation. Surgery was advised in patients who had 2 or more high-risk features. Again, any cyst, 2 or more high-risk features, concerning features on EUS, or an FNA with high-grade dysplasia or cancer. I think this was all generally well accepted until they got to this statement, which said, if you had no significant change in this cyst over 5 years, you should stop surveillance permanently. And this is where these guidelines, the AGA guidelines, are highly controversial. And I think most folks who manage patients with this disease, most surgeons, no one believes this or agrees with it. There are some new data coming out as far as how well these new guidelines perform. So this was a retrospective study looking at patients with suspected branch duct IPMN who had a minimum of 5-year follow-up. And overall, the results were that only 1% of patients in this group developed cancer after 5 years, and that really it was having 2 high-risk features was the thing that portended a bad diagnosis or a bad outcome. Again, similar to what the AGA guidelines were saying. This was a very hot topic at last year's DDW. And a lot of large centers, including our own, looked at our own experience to see what our outcomes would be if we applied both the Fukuoka guidelines and the AGA guidelines to our own experience with managing cystic patients with pancreatic cysts. Most of these studies looked at all cyst types. We looked at simply only IPMN, and I'm not going to get through the sort of number soup here, but you can see that looking at all of these studies, the rate of malignancies in these groups went from anywhere from 5% up to 35%. Missed cancer rates, again, very wide ranges here, and an overall unacceptable rate of incorrect surgery or unnecessary surgery. These studies have a lot of limitations. They're all retrospective. It's very hard to do prospective studies in these patients because this is a very slow-growing disease. You need to follow these patients for 10, 15, 20 years, and most of these patients are in the 60 or 70-year age group. There's one of the other limitations that they're comparing apples and oranges. Fukuoka guidelines are specific for IPMN, whereas the AGA guidelines take into account all cyst types. So I'm not sure how you can equally compare the two. Patient selection was a problem. All of these studies included, some included symptomatic patients, which technically the AGA guidelines are not for. Some excluded if they had no prior EOS. Some only did if they had surgery. And they defined cancer. They all defined cancer differently. So ultimately, I think these studies demonstrate the inherent flaws with using the current pancreatic cyst guidelines to manage these patients. They're all based on weak data. There's no good prospective large natural history studies. And these are all based on morphologic findings. So you know just as well as I do that if your radiologist places the cursor 1 millimeter over, your 2.9 centimeter cyst is now a 3.1 centimeter cyst, and that may lead to further testing whether necessary or not. We really don't know what the real risk of progression to cancer is. As I said, if you look at large retrospective series, it seems to be about 1 to 3%. But we really don't know what the appropriate surveillance intervals should be. So maybe this is as good as these guidelines are going to get, and maybe we should stop fretting over them and just use our best clinical judgment. Sort of as Amy discussed, our goal when we're managing these patients is really to identify that subgroup who are at the highest risk for developing cancer and then perform curative or preventative surgery. And it seems that the most high-risk patients are those that have an intramural nodule or those who have a main duct, associated main duct dilation. So the best way that we can do this is really to improve our selection of these patients, really those that we can confirm have an IPMN and those that we know have an IPMN that we can stratify to which are more high risk than not. So there are some new developments in how we can do this endoscopically. Traditionally, the evaluation would typically involve an endoscopic ultrasound, fine needle aspiration. We would aspirate the fluid, send it for cytology. The accuracy of cytology for cancer is about 50%, so it's basically a coin flip. And we would also send it for a tumor marker called CEA. An elevated CEA over about 200 has about an 80% chance of being accurate that your cyst is a mucinous cyst, but again, that means 20% of the time that's incorrect. And you can also have mucinous cysts or IPMNs with lower CEA levels, below 200. So again, we need better ways of stratifying our patients. So you saw a little bit about this earlier in the Barrett's talk, confocal laser endomicroscopy. And what this is a laser probe that's inserted through the FNA needle, and you can put it up against the cyst wall, and allows you to get or visualize in real time the microscopic structures of the cyst wall lining. And here you can see things such as papillary finger-like projections. You can see disorganization and dark clumps of cells, which may be concerning for neoplasia. And the Europeans have done some amazing work where they were able to tease out the different patterns one would see on this needle-based confocal endomicroscopy. So for example, on an IPMN, one would expect to see a papillary finger-like projection, a serous cystadenoma, which is not a precancerous lesion, it's benign and does not really require any follow-up, that would have a different pattern. It would have what's called a superficial vascular network, where you can identify all of these dense vessels, as you would see here in pathology. And something like a pseudocyst, you would have a lot of debris and no real epithelial wall lining. There is another new tool to our armamentarium, and this seems very, very obvious, but it took many years for someone to actually develop this, and that is just the ability to put a biopsy forceps through our FNA needle. As I mentioned, sticking a needle in a cyst, taking the fluid out and spinning it down looking at cells, these cysts often don't have any cells. The cyst fluid often doesn't have any cells in it. But if you can actually take a bite of the biopsy of the cyst wall and have your pathologist look at it, that can actually be quite powerful. So this is one example of a case we did. This was a young woman, 46, who had a 2.4 centimeter cyst in the pancreatic body. Our pre-operative or our pre-workup suspicion was that this could be an IPMN, and if it was in a 46-year-old, that may portend close follow-up, because she is very young, not typical age group for someone to develop this. The cyst fluid CEA was 188, so really just below that cutoff of 192. And the cytology only showed benign ductal cells, but we did the cyst wall biopsy, and our pathologists were able to see, and here you see the nice specimen, they were able to confirm that this was an IPMN with low-grade dysplasia. That doesn't necessarily tell us the whole story, because this is just one bite of one part of the wall. So not that we suspected there was anything higher risk there, but the point is we were able to confirm a pathologic diagnosis. This was another patient a young woman with early breast cancer who underwent curative surgery, and on her surveillance imaging was found to have an incidental cyst in the body of her pancreas. We did an endoscopic ultrasound, and she did have a small nodule, which would be considered a high-risk feature. And though very mild, she did have a prominent main pancreatic duct. We watched this woman closely, and when we repeated her endoscopic ultrasound, we performed the confocal laser endomicroscopy, and sure enough, here you see this papillary finger-like projection, and we used the microforceps to also confirm that it was an IPMN with low-grade dysplasia. One other factor that I think may make its way into the guidelines and future iterations of guidelines is growth rate. And this was one very nice study demonstrating that branch duct IPMNs that turn malignant have a statistically higher growth rate compared to those that are benign. And this is an easy thing to follow because we're following these patients radiographically anyway. So this may prove to be a very easy and efficient way to manage patients, but there's more to follow with that. Probably the holy grail is being able to identify a biomarker in the fluid that helps you differentiate a high-risk cyst versus a low-risk. Cyst fluid's easy to obtain. We often can run molecular tests on just a few drops. Ideally, we want something that correlates with the severity of dysplasia. And again, the CEA, which is the standard one that most people do, has zero correlation with risk of malignancy. So if you have an IPMN with a CEA of 8,000, that has no bearing on whether that cyst is higher risk of cancer as opposed to a branch duct IPMN with a CEA of 400. I think this is where this whole field is going. This was a monumental study published last year in Gastroenterology where they had pathologically proven cyst types. They did molecular analysis for both the presence of relevant gene mutations and the absence of relevant genes or gene mutations, and they combined them with demographic information and radiologic information or EUS information. And when they combined all of these factors together, they were able to demonstrate that 67 of the 74 patients that underwent surgery in this group wouldn't have needed surgery, meaning that they had a lesion that did not require surgery, that never would have become cancerous, and that potentially would have decreased unnecessary surgery by 91%. So this is really what we're waiting on, is some sort of panel that we can just put a few drops of that cyst fluid on and help us sort it out along with radiographic findings and patient demographics. So I'll end with just a couple of cases just to show some real-world examples. So this is actually the same patient Dr. Lucas presented, 77-year-old man with 2 first-degree relatives with pancreatic cancer, a sister and a brother. When Amy ordered his EUS and his MRCP, he happened to get the EUS first, and we found 3 cysts. The largest was about 1.9 centimeters in the neck. The CEA was in the indeterminate range, and the cytology just showed some atypical cells. We followed him closely, and on a repeat endoscopic ultrasound, he now had 5 cysts, but most importantly, the largest cyst was now over 3 centimeters, and there were 2 nodules in there, which would be considered high-risk features. And again, these patients are all managed in a multidisciplinary approach. We have a weekly pancreatic tumor board meeting where all these patients are discussed. There's surgeons, medical oncologists, radiologists, pathologists, and gastroenterologists, and it was decided that this patient would benefit from surgery. And as Amy discussed, he underwent a laparoscopic distal pancreatectomy, which showed multiple branch duct IPMN with high-grade dysplasia and no invasive cancer. So this would be considered a win. This is another patient, 77-year-old woman who was found to have a very large pancreatic cyst. Incidental, it was asymptomatic. It was over 4 centimeters. She was studied with a CT, and we had performed an endoscopic ultrasound. The appearance on endoscopic ultrasound was that of a typical serous cystadenoma. Again, a benign neoplasm that has 0 risk of turning malignant. We did fine needle aspiration and got no diagnosable cells, but we said this is most likely a serous cystadenoma. We don't think it needs to be followed closely. A few years later, she lands back in the clinic, I think for a burp or a hiccup or something, and she got scanned again, and now the cyst was bigger in size. The radiologist noted a mural nodule. They said it communicates with the main pancreatic duct, which serous cystadenomas never do. They said the main pancreatic duct was dilated to 6 millimeters, which would be a worrisome feature. And they concluded that the findings were concerning for an IPMN with high-risk features. Now, this is completely opposite to what we thought we were dealing with initially, and now this patient would be considered for surgery, again, as a cancer-preventing operation. So in her case, we now had the ability to do sort of higher-level testing, so we did EUS-guided confocal laser endomicroscopy. And what you see here is a large cyst, a number of microcystic components here, and then large cystic components here. And in a second, you're going to see the FNA needle go into one of those large cystic components. And then we have this preloaded with that little laser probe, that confocal laser probe, and we're going to gently touch it against the cyst wall. And then on the other monitor where the confocal is, we're seeing what the cyst wall lining looks like in real time. And for those people who do CLE, they'll know that this is a pretty typical superficial vascular network, which is really pathognomonic for a serous cystadenoma. So in this case, we were quite confident of our diagnosis that this patient did not have an IPMN, did not need surgery, and actually could be released from surveillance. So in summary, there are imperfections in the guidelines. Again, these are mostly dependent on morphologic cyst features. I think they send a mixed message, and I think this is not where the answer lies. We now have new advances in the preoperative diagnosis and of these patients with nCLE and cyst wall biopsies, and we can look at growth rate as a potential new marker. And then again, I think the real holy grail is the development of new cyst fluid biomarkers. Again, things that can be tested for multiple genes with just a few drops of fluid. So how do I approach the patient with a pancreatic cyst? So typically I will do a very thorough history and physical, and also get a good family history. I think Dr. Lucas's talk hammered that point home, that family history can have a huge impact on the outcome of these patients. We'll review their imaging. We preferentially like to use MRCP, and we insist that patients get all of the old scans that they can get, whether they were CAT scans for other reasons or spine MRIs. We want to be able to see if that cyst was there in the past and if it's changed in any way. I presume all of these cysts are IPMN until proven otherwise, unless there's some pathognomonic feature on the imaging that tells me it may be a serous cystadenoma, or something in their history that tells me it may be a pseudocyst. As I said, over 90% of the cysts you see are IPMN, so I presume they're IPMN until proven otherwise. And then I consider surgery if they have high-risk pathology at any point in their workup. When do I perform endoscopic ultrasound? Certainly if imaging shows an intramural nodule, any type of main duct dilation, if it's a large cyst, or if the cyst has grown somewhere between 2 and 5 millimeters on surveillance. I don't always do an FNA on all of these patients. It's really more just to get more detail that the cross-sectional imaging may not see. And then I will consider an EUS in patients who don't have these high-risk features, but in patients who may have multifocal disease, if the patient's had a suspicious cyst with a prior indeterminate FNA, or if it's sort of moderate in size between 2 and 3 centimeters. And I may couple that with patient factors, such as if they are a very young age. Again, cysts are typically found, IPMN are typically found in 60 to 70-year-olds, but if you find a large cyst in a 40 or 50-year-old, you have to really be concerned that, is this a precancerous cyst and do we have an opportunity to intervene? Anyone with a personal history of pancreatic cancer will also do an EUS on if they have a cyst, or a family history of pancreatic cancer or cyst. And then as Amy nicely laid out, anyone with genetic syndromes such as Peutz-Jeghers, FAP, or Lynch syndrome. And then follow-up, if they have high-risk features, they need to see a surgeon. They're discussed at our multidisciplinary tumor board. If the patient is declining surgery, then we will offer close surveillance with MRCP alternating with endoscopic ultrasound every 3 to 6 months, again, if they have high-risk features. If they have low-risk features, I reassure them. I tell them, look, the likelihood that this is going to turn cancerous is about 1%. It's not something you should lose sleep over, but it's not something you should forget about. So we'll see you back in 6 to 12 months with another MRCP. Assuming it's stable, we'll repeat an MRCP in 12 months. Assuming it's stable there, I usually go 12, 18, or 24 months, depending on the size and the patient's age. And any change in size or features, we'll consider an endoscopic ultrasound. So thank you very much.